Hello, my name is Islam Shireen. In the next few minutes, I'll try to explain the use of the direct ophthalmoscope for non-ophthalmologists. This is becoming of great importance to different specialties, including physicians, pediatricians, intensivists, neurosurgeons, and neurologists. I'll try to cover 4 points in my talk, the first of which is the optics of the direct ophthalmoscope. The device was invented in the 17th century by Hermann von Helmholtz. It consists of a handle, and this handle contains a rechargeable battery or a group of batteries, and a head which contains a bulb, which is the light source, a set of apertures for the light source, and we'll talk about that, and then a set of lenses to compensate for the possible refractive error of the examiner and the patient. The view provided by the direct ophthalmoscope is monocular. This means that one eye can see at a time and we cannot see with both eyes simultaneously. It's non-stereoscopic. This means it's only 2D. The field of view is narrow, about 5 degrees, and it's magnified to about 15 times of the normal size. So the device contains a bulb which produces light. This light is reflected at right angles to project as a spot through the iris of the patient to illuminate the retina. This reflection can be done whether with a mirror or a prism. The user looks just above the mirror. So we have a small mirror here, and the user looks just above the mirror of or the refracting prism, and the illuminating retina is seen directly by the user. The head contains a disc or a wheel here that we can rotate to use lenses of different powers to correct the refractive error of the patient or the doctor. And there is a set of filters to cut out reflections and reduce the glare. And we can control the aperture of the light source. So there is a small spot of light which is used when the pupil is not dilated, and then there is a large spot of light which is used when the pupil is dilated, and there is a slit aperture which can be used as a primitive slit lamp to appreciate the depth of the anterior chamber of the eye. The brightness of the light can be adjusted with a rheostat. So there is like a rotating collar here, in which we press and rotate to turn on the light and control the intensity. The direct ophthalmoscope has several advantages to be used by non-ophthalmologists and even by ophthalmologists. It's cheap and easy to use more than the indirect ophthalmoscope. It gives much better magnification, times 15, in comparison to the direct ophthalmoscope, in which the magnification is in the range of times 2 to 3. It's excellent for assessing the posterior pole, especially the optic disc and the macula, which means the central part of the fundus. And by rotating the lens wheel, we can change the focus to see different parts of the eye. So when we dial more plus lens, we shift the focus more anteriorly, and we can focus on anterior structures like the cornea, the lens, etc. The head of the direct ophthalmoscope has several auxiliary functions. So there are, as we mentioned, the large spot size, medium spot size, small spot size, and half light. There is the red-free light, which is better to appreciate lesions that are red in color, like the blood vessels and retinal hemorrhages. We talked about the slit, and it's used to examine the anterior segment of the eye. We have the blue light, and we have the grid, and we'll talk about the use of the grid later on. One of the main disadvantages of the direct ophthalmoscope is the limited field of view. So this device can only visualize the posterior pole of the eye. Dilating the pupil will give us a bit of better field to see, but again, it's not comparable to the indirect ophthalmoscope, which provides much better visualization of the peripheral retina. A second disadvantage is the monocular view, so we cannot appreciate the depression or the elevation of the lesion as good as with indirect ophthalmoscope, in which we use both eyes to see. And the light of the direct ophthalmoscope is dimmer than the indirect ophthalmoscope. The BIO stands for binocular indirect ophthalmoscope, or the slit lamp by microscopy, and this makes the fundus details less visible. The second point to be covered in this lecture is how to do the pupil dilation. First of all, we need to know that the pupil dilation is mandatory to increase the field that we see in the fundus of the patient. So without dilation, we can only see a very small part of the posterior pole. This gets better with proper pupil dilation. We commonly use cyclopentolate 1% or 0.5% eye drops to dilate the pupil. Those are parasympatholytic. This means that they are from the family of the atropine. They block the parasympathetic supply to the constrictor pupillae, allowing the dilator pupillae to act unopposed. They achieve maximum cycloplegia within 30 minutes and recovery of accommodation within 2 to 3 hours. Here, we need to differentiate between the pupil dilation, which is important to examine the fundus, and the cycloplegia. The cycloplegia means paralysis of the accommodation. The patient cannot use the ciliary muscle to see near. Another important category of the dilating parasympatholytic drops is the tropicamide. They start their action of pupil dilation as early as 20 minutes, and the mydriasis lasts for 6 hours. They have less cycloplegic effect in comparison to the cyclopentolate. The third point to be covered in our lecture is the examination technique. So we start by directing the head of the device towards the patient and looking from the opening to be used to see, and then we dial the rotatory disc if the doctor is immetrope. So we start with putting 0 in this space. We start by examining the red reflex. This is important to judge the clarity of the ocular media. If there is any kind of media opacity like cataract or vitreous hemorrhage or corneal opacity, the red reflex will not be bright. And then we move on. There is an important rule called the right, and left, left. If I'm examining the left eye of the patient, like as we can see here, the doctor should hold the direct ophthalmoscope in his left hand and use his left eye, and vice versa for the right eye. We start to go from slightly temporal and aiming at finding the optic disc, which is located slightly nasally. The optic disc is an important landmark. We always try to examine different quadrants and go back to the optic disc in order to get the correct orientation of our location in the fundus. As you can see, the direct ophthalmoscope allows only a small examination of a small part of the posterior pole, so we need to navigate with changing the direction of the device to see different parts of the fundus. The last part to be covered in this lecture is clinical examples of the changes that we may see in the patients. So this is an example of a normal optic disc. As you can see, the color is salmon pink. There is a normal pink color of the capillaries over the surface of the optic disc. There is a normal optic cup. The normal optic cup should measure less than 0.3 to 0.4 from the vertical disc ratio. So we have what we call the cup to disc ratio. This should not be larger than 0.5%. And in addition, we need to judge the similarity between both eyes if there is any discrepancy. And then we have a normal well-defined disc margins. As we can see, this will change in pathological condition. One of the very commonly seen conditions by other specialties is the papilledema. Papilledema means that there is a rise of the intracranial pressure, which is reflected through the CSF and gives edema of the optic disc of both eyes. In early papilledema, we will find that there is what we call hyperemic disc edema. So there is an increased hyperemia of the surface of the disc, and the optic cup may be preserved or lost, may be preserved in very early papilledema. The pupillary the margins of the optic disc will be slightly obliterated and ill-defined, not like in normal optic disc. Spontaneous venous pulsation, if it's seen, it negates the presence of papilledema. Absence of spontaneous venous pulsation cannot confirm papilledema, but absence of a previously recording spontaneous venous pulsation indicates a raised intracranial pressure. So if one doctor documented that he or she has seen spontaneous venous pulsation and a second doctor came for a second exam and he did not find this, this is a sign of early papilledema. As I mentioned, identification of venous pulsation in at least one eye means that the intracranial pressure is normal. In cases with established papilledema, the visual acuity may be normal, or the patient may suffer what we call visual obscuration. So he or she will have very short transient disturbance of the vision. There is a severe hyperemic disc edema and moderate elevation. The margins are ill-distinct, they are edematous. There is absence of the physiological cup in established cases. There is venous engorgement and peripapillary flame-shaped retinal hemorrhages and frequent cotton wool spots representing areas of retinal ischemia like these ones. And there is circumferential retinal folds called the Patton lines, especially temporally on the temporal part of the disc here. Cases with chronic papilledema will pass to what we call the secondary optic atrophy, in which the visual acuity may be affected and the visual field may start to constrict. There is still disc elevation, however, it's not very hyperemic, it becomes pale, and the cotton wool spot and hemorrhages are no longer present, they will disappear over the time. We can find some opticociliary shunts, so abnormal vessels connecting between the ciliary blood vessels and the peripapillary blood vessels, and there are some drusen-like crystalline deposits called corpora amylaceae that can be present on a disc surface. So you may find a refractile crystalline deposits on the surface, which is called the corpora amylaceae. Another condition to be differentiated from the papilledema is the optic neuritis. Here we have inflammation of the optic disc, so the vision is severely affected. It's usually unilateral. The most common cause is demyelination. However, other causes include para-infectious, that's to say post-infectious or post-immunization, and infection, including sinus-related infection and other infections like cat scratch disease, syphilis, or Lyme disease, or non-infectious causes like the sarcoidosis and systemic lupus erythematosus. This condition is characterized again by hyperemic edema. However, the vision is affected. There is what we call a relative afferent pupillary defect, and it's unilateral. This helps us to differentiate it from the papilledema. We have what we call the primary optic atrophy in cases of compressive optic neuropathy or trauma to the optic nerve or demyelinating disease. This will end up with what we call a primary optic atrophy, in which the disc will become pale, so there is loss of the normal salmon pink color. The edges of the disc are very well preserved, in contrast to the secondary optic atrophy, which happens after the disc edema. This is a secondary optic atrophy, so the patient had either optic neuritis or papilledema and passed untreated to end up with this secondary optic atrophy. Again, there is loss of the normal salmon pink color of the disc, there is loss of the optic disc cup, there is ill-defined retinal margin, and there is sheathing of the blood vessels. They are sheathed, so we can find like a transparent sheath around the retinal blood vessels. Those are the signs of secondary optic atrophy. One of the important tests to differentiate between the papilledema and the optic neuritis is the swinging flashlight test, or what we call the relative afferent pupillary test. So when we shine the light over the sound eye, this eye will constrict directly and the other eye will constrict consensually. When we move the light quickly to the affected eye, the eye with the optic nerve problem, this eye is not capable of maintaining the constriction and it will go into paradoxical dilation. It should continue to be constricted. It cannot do that and it will go into paradoxical dilation. Not only this eye, but also that eye consensually will dilate. And if we will move with the light back to the sound eye, we'll find that it was dilated and will start to constrict, and vice versa. When we move the light to the diseased eye, it will dilate. As we mentioned, this is how the indirect ophthalmoscope looks like. It's usually used by ophthalmologists. It enables examination of the peripheral retina, like in this baby with retinopathy of prematurity. Usually the changes are present in the peripheral retina, so the direct ophthalmoscope will not be the best device to detect those changes, and the indirect will give much better view. Thank you for listening to this lecture. I'm looking forward to seeing you all soon again.